Hi class, so we're going to dive into chapter 7, but to be honest, the majority of this is going to be covered in lab, so I'm just going to flip through it and talk. The PowerPoint is 227 slides long, and it gets very overwhelming, and so for the majority of it, I'm going to be flipping, and we're going to cover it all in lab. Let me switch to screen share mode with you. And we're going to run through this thing real quick. I know some of you get into your routines and you like to listen to the lecture and watch the PowerPoint. So I'm doing this for you, but it's really not necessary because typically chapter 7 is not included in the lecture material for the course. We have the axial skeleton and the appendicular skeleton. The axial skeleton, is the longitudinal axis. This is our major head, neck, trunk, abdomen, thorax, skull-associated bones, vertebral column. About 40% of the bones in our body are in this area. There they are, listed for you. It supports and protects the brain, provides areas for our body cavities, and provides attachment for certain muscles. It's also there to adjust the position of the head, neck, and trunk, perform our respiratory movements, assist with breathing, stabilize positions in parts of our appendicular skeleton, and forms joints with the appendicular skeleton to limit our movement but still keep those joints very strong. So you can pause the video and go back and answer these 3 questions. Let's talk about our skull bones. I'm never going to ask you exactly how many bones are in our skull, how many bones are in our face, how many bones are in our cranium, but I might ask you what they are, or I might say which of these is not a facial bone, or which of these is not a cranial bone, or etc. So here they are, again, listed for you. Do you have to know them? Yes, we'll be going over them specifically in lab over it's like a 3-week period that we'll be looking at bones in lab. So skull bones and facial bones are there to protect our mouth, to protect the entrance to the digestive tract and our respiratory tracts, our mouth and nose. Basically, they're also there for facial expression. There they are, zygomatic, maxillary, nasal, lacrimal, vomer, mandible. You'll be learning all about them. This video is not linked to the PowerPoint, but if you go into the Mastering A&P website, you'll find all of the videos there. The cranial bones enclose the cranial cavity. There's actually a fluid-filled chamber that's cushioning and supporting the brain, and then on the inner surface, there's a point of attachment for all the blood vessels, nerves, and membranes as well. The outer surface of the cranial bone, again, provides more attachment area for muscles, and there's something called a calvaria. This is our skull cap. This forms the roof of the skull, and it's formed by the occipital, parietal, and frontal bones. There they are. You should, by looking at this, be able to tell anterior from posterior. This is the front, this is the back, occipital, temporal, parietal, frontal, and then the ethmoid and sphenoid bones are also kind of inner bones of the skull. They're lesser known, but they're actually probably more important. Again, try to look up those videos on mastering. There's also, if you go into YouTube and type in Dr. Schaefer's class, one word, no spaces, Schaefer's, Schaeffer. You will find all of his videos where he's actually going over the bones with a pointer and the exact bones that are in lab. So there are sutures associated with the skull, and again, these are all on your practical list that you need to know for practical 2, but they're immovable joints, and they're bound together by dense fibrous connective tissue. There's 4 major sutures: the coronal, the squamous, the sagittal, and the lambdoid. There they are in all of their glory. You can pause the video, go back, and answer these questions. The facial bones include the nasal bones, the lacrimal bones, the palatine bones, the zygomatic, and the maxillae, as well as the inferior nasal concha. The vomer and the mandible just come as a singular. They're not paired. And our cranial bones from an anterior view include the frontal bone and the sphenoid bone, which you can see just a little bit of. It's like on the sides here. The cranial bones from an anterior view, you can also see a little bit of the ethmoid bone, kind of on the roof of the nasal cavity. And there again, the sphenoid bone, you can see it's this purple bone, and the ethmoid bone is this green bone. You can see it kind of deep in that area. The parietal bones, the occipital bone, Occipitals on the back, parietals on the sides, the temporal bones. And the temporal bones provide attachment sites for our mandible. There's a mastoid process, which is behind the ear. You can kind of feel it. It's more of a rounded, massive process. And then styloid process, which is very sharp and pointy, which is providing access for muscles to attach to the hyoid bone. That one you can't feel. It's very, very sharp and pointy. You'll be able to see that on our lab models. That's the back of the head. You can pause the video, go back and answer these questions. Let's talk about some surface markings. There's the frons on the forehead. There's the superior and inferior temporal lines, and there's a squamous part of the temporal bone, which is just the flat surface. Again, your practical list is outlining exactly what you need to know for lab as well as lecture. It's your kind of boundary guideline. The external acoustic meatus, or external auditory canal, as it's sometimes called, it's just the canal on the lateral surface and it ends on the inside of the brain. You can see it as the internal acoustic meatus when you look inside the skull. There's also the zygomatic process, which fuses with the temporal bone to create the zygomatic arch. And the mandibular angle, mental protuberance, and alveolar processes are all markings on our mandible. And there all those features are for you. I should note as I'm lecturing here that on an exam, I may give you a diagram. I probably won't. I try to steer clear of those as much as I can, but it's possible. Your quizzes will not have diagrams on them. It'll just be straight application of the terms, kind of like what we will do when we get to muscles, just straight application of the terms instead of labeling diagrams. I'll keep the diagrams in the lab portion of the class, not in the lecture as much as I can. We also have frontal sinuses, which are the hollow spaces in our frontal bone, and the petrous part of the temporal bone, which encloses the area of the middle and inner ear. The internal acoustic meatus is on the medial aspect of our skull, and the hypoglossal canal, which is a passageway for hypoglossal nerve, and you'll see that again on the inside part of our ear. You can see that hypoglossal canal and the internal acoustic meatus, sometimes called the internal auditory canal. You can pause the video, go back and review. Just moving through, you have the foramen lacerum, the foramen ovale, and the carotid canal. You will see these in lab, and you'll have to identify their structure and identify which one they are in lab. In lecture, you have to know their purpose. So you have to know what they're there for. The jugular foramen, stylomastoid foramen, foramen magnum, all passageways for either nerves or veins. The foramen magnum would be the spinal cord. And then you have fossas and condyles. These are just either rounded processes that are kind of projecting off of bones, allowing for articulation between either the skull and the vertebrae, or the temporal bone and the mandible. And this inferior and superior nuchal lines are on the occipital crest. They're just attachment sites for muscles and ligaments. So you can see them all here on this inferior view of the skull. You also have the internal occipital crest anchoring blood vessels and membranes, stabilize the brain. Right here, the foramen magnum. And you can pause the video, go back and answer questions. Thank you, sweetie. Never know when she's going to bust in here. Some sphenoid bone features. Sphenoid bone is probably one of the more complex bones of the skull, or maybe even of the whole body. You have optic canals, the sella turcica, which is a little saddle-shaped area on the sphenoid, the hypophyseal fossa, which is just a flat depression on the sella turcica, and the sphenoidal spine. The greater and lesser wings, they're kind of like little stair steps, as you'll see when we look at the skull itself. And the sphenoid bone has several foramen that are associated with it. These are carrying blood vessels and nerves. The foramen spinosum, ovale, rotundum, and then the superior orbital fissure, which is just a fissure in the back of our eye. You'll see that when you look at the skull. Here is our kind of bat wing shaped sphenoid bone. That's what it looks like. The sella turcica is this nice saddle area, the hypophyseal fossa. right there. That's where your pituitary gland sits, and then you have your lesser wing on top, greater wing on the bottom, optic canals, optic fissure, and then the small foramina, allowing for blood vessels and nerves. The body of the sphenoid forms the central axis of the sphenoid itself, and there's sphenoidal sinuses. There's also a pterygoid process, which goes into and allowing for attachments of the mandible and soft palate. Here you see a different view of the sphenoid. This is an anterior view. The ethmoid bone is another kind of oddball in there. It has a cribriform plate. This cribriform plate extends upward into kind of the base of the cranial cavity, and you'll see this. The crista galli is a little bony ridge that comes up as well. And the ethmoid bone has lateral masses and a perpendicular plate. The perpendicular plate helps to form part of our nasal septum. Again, it looks kind of weird when it's by itself, but when you see it on the skull, it will make more sense. The palatine bones form the posterior part of the hard palate. You can really only see them when you take the mandible off and you flip the skull upside down. You can see those. This is showing you the perpendicular plate and the horizontal plate of those bones. You can pause the video and go back. Let's talk about the orbital and nasal complexes. The orbital complexes form the orbits of the eye. The nasal complex surrounds the nasal concha. The orbital complex is formed by 7 bones. You should know these: frontal, zygomatic, maxilla, lacrimal, ethmoid, sphenoid, and palatine all make up the orbital complex. So the orbital complex has bony features like a lacrimal fossa, superior and lateral surface of the orbit. There's also a supraorbital margin. This is the thickened part of your frontal bone, kind of creates a little brow ridge. Then the supraorbital notch. This is a little passageway for blood vessels to your eyelids and eyebrow. The lacrimal sulcus is the groove on the lateral surface of the lacrimal bone, marks the location of the lacrimal sac. It's this little inner pocket. And the nasolacrimal canal is formed by the maxilla and lacrimal bones. It's basically allowing your tears to drain into your nasal cavity. You have the infraorbital foramen, marks a little sensory nerve that's going just underneath of your eye, and then the zygomaticofacial foramen, which is on the anterior surface of the zygomatic bone, just for some more sensory information from your face. Here you can see some of these features. Lacrimal bone in here. You can see the infraorbital foramen, the zygomaticofacial foramen, parts of the sphenoid bone dipping back there. This would be the superior orbital fissure. I'm just wondering why it's not labeled. That's what that is. What's some other features? The nasal concha, you can see here. We'll look at a better view. Let's talk about the nasal complex, and we'll probably get a better view of that nasal cavity. The nasal complex forms the nasal cavities and the paranasal sinuses. There's boundaries, and again, I'm not going to say which of these are the boundaries of the nasal cavity, but you have to know what the nasal cavity is. You have to know what bones make it up. So it's good review and important for everything. Here you can see that weird shaped ethmoid bone really kind of nesting in that center area behind the nose. You can see that palatine bone, which kind of looks a little strange. It's just another weird shaped bone. Inferior nasal concha. There's also the superior nasal concha and middle nasal concha, which are made up from the ethmoid bone. Again, all of this will make sense once you see it on the skull in lab. The paranasal sinuses. Yes, ma'am.
There's string on my panties.
Okay, I'll get it in a minute. Thank you, honey. Can't have string on your panties. All right. Nasal complex has different chambers to it, like the sphenoid sinuses, the ethmoid air cells, which are again just they're there, and they're basically like a honeycomb area of bone that fill with air and fluid. Sometimes they have mucus in them, depending on if there's infections. The maxillary sinuses are there, kind of below the nasal cavity. So those are our largest sinuses. Here you can see a little bit better some of these pockets, the ethmoid air cells, like I was talking about, this kind of honeycomb-like network of chambers. You can see the maxillary sinuses here, these hollowed out spaces of the maxillary bone. And the nasal cavities. This is your actual nose itself. Right, looks kind of weird without the bones there. Go ahead and pause the video, go back and review these questions. We're just going to keep charging through. The mandible is our lower jaw. You have a ramus, which is kind of this arm that goes up towards our ear, a condylar process, which is where the temporomandibular joint is, the mandibular notch is this little notch in there, and the coronoid process is another little projection for the temporalis muscle. The body is the main part of our mandible, which is where our teeth are. There, you can see that condylar process. You can see the coronoid process here, allowing for that temporal bone to hold in place. Other features of our mandible include something called the mylohyoid line, the mandibular foramen. You see those here. There's a hyoid bone. Typically, we usually just have a singular hyoid bone in lab. It's usually not attached, and you don't need to know the greater and lesser horns of the hyoid bone, but there it is. Our auditory ossicles, I will test you on these rather when we get into our special senses towards the end of the semester. So I'm skipping over these here. I will not test you on them here. In this section, we will be tested on them when we get to auditory sense later on. But they're very small, the malleus, the incus, and the stapes. You can pause the video and go back if you need to. The fontanelles are the fibrous areas where the skull has not yet fused on a fetal or infant skull. And there's an anterior fontanelle. This is the largest fontanelle. This is the soft spot. It usually goes on until about age 2, once the skull finally fuses all the way. There's also a sphenoidal fontanelle, a mastoid fontanelle, and an occipital fontanelle. They're just smaller, less noticeable, but they're still there nonetheless. So here you can see these fontanelles, the occipital fontanelle. You can see the mastoid fontanelle back here and the sphenoidal fontanelle here. This is our very large anterior fontanelle or soft spot. You can pause the video, go back and answer these questions. We're going to continue on with the vertebral column made of 26 bones divided into 5 regions. You have the cervical region, which is 7 vertebrae, the thoracic region, which is 12 vertebrae, the lumbar is 5, the sacrum makes up the sacral region, and the coccygeal is the coccyx or tailbone. The average length is about 28 inches. And it's basically there to bear the weight of the head, neck, and trunk, transfer the body weight to the lower limbs, protect the spinal cord, and help maintain upright position. You have the thoracic curve and the sacral curve. These curves develop before birth, and these are the primary curves of our spine. And then the secondary curve, which is the cervical curve, this is when you are finally able to lift and hold your head up. And then the lumbar curve helps your body stand erect, stand up. There they are. 7, 12, 5, 5, 4. There's typically 5 fused sacral and 4 coccygeal vertebrae. And this is just showing you the differences. This chart comes from your book, shows you the differences between the vertebrae. You should know them in lab. I will actually, on your practical, have a vertebrae out, and I'll say, which type of vertebrae is this? And you'll have to identify it as cervical, thoracic, or lumbar. I won't do that to you in lecture, but you do need to know differences. So each vertebrae has 3 basic parts: a articular process, a vertebral arch, and a vertebral body. The vertebral foramen varies in size depending on where the vertebrae is from. There they are. Here's a video which you can look at on your own on Mastering A&P. So again, the vertebrae are articulated with one another through what's called an articular facet. This is the concave surface on each of the articular processes. This forms the joint of the adjacent vertebrae. There's a superior and inferior articular process on the vertebrae. So here you can see the superior process and inferior process on those articular facets. The vertebral arch has a lamina, pedicle, spinous process, and transverse process, all of which you need to know for your practicals. There they are. The vertebral canal is where the spinal cord will be found. The intervertebral discs are the fibrocartilage pads that are separating each vertebrae from one another, and the intervertebral foramen is the space in between the successive pedicles or in between the processes. of the vertebrae. And this is where blood vessels and nerves will leave or come into the vertebrae. Naming conventions, you typically refer to it as a C, a T, an L, an S, or a C, usually. And then the number. So which number going from superior to inferior, so C1 would be that first cervical vertebrae that's right underneath of the skull. You can pause the video, go back and review. Let's talk about cervical vertebrae first. There are 7. These are the smallest vertebrae in the vertebral column, and they go from the occipital bone all the way down to the thorax. They have a very large vertebral foramen because the spinal cord here is much larger, it's thicker, and the vertebral body is very small and light because it's only supporting the head. The cervical vertebrae have a spinous process called a bifid. They have a transverse process that's very short and stumpy. The transverse foramen will allow the arteries and veins to come out and into the brain, and the costal processes go to either side of the body. There you can see what they are. The first 2 are very specialized and have special functions. C1 is called the atlas. There's no spinous process or vertebral body. It's very large and round. Vertebral foramen, because the spinal cord at this point has just left the brainstem. It articulates with the occipital condyles and allows for this motion. The axis is C2. It has a little dens or odontoid process, which articulates around that axis, and this is allowing for that no motion, that rotation of the head. There you see the 2 articulated together, special transverse ligament holding them in place. There they are. The last cervical vertebrae is C7. This is the vertebra prominens. This is the very prominent vertebrae. This one sticks out of your back a little bit. It has a very large spinous process that can be felt through your skin. The nuchal ligament, or ligamentum nuchae, is an elastic ligament that connects the vertebrae with the external occipital crest. So these are special ligaments that go up the back of your neck, and they kind of act like a bowstring to maintain that curvature without any muscles. It's just a ligament instead of muscles. There they are. The thoracic vertebrae, there are 12 corresponding with the 12 pairs of ribs. Each one's slightly larger as they go down, and they because they're holding increasing weight the lower they go. There they are. They have a slender spinous process. They have costal facets on their dorsolateral side to allow for rib articulation. And you see those here, the costal facets, these little flattened areas, allowing for the ribs to articulate. And these questions, you can pause the video, go back and review. The lumbar vertebrae are the largest vertebrae. They're very thick because they're supporting the majority of your body weight. The superior and inferior surfaces are very oval. There's no costal facets because there's no ribs here. They have a very slender transverse process. They have a very stumpy spinous process. And their articular processes face medial or lateral. They're very thick, so they're usually very easy to tell, very easy to identify. Sacrum are 5 fused vertebrae. They begin fusing after puberty. They're completely fused by about 25 or 30. They are the purpose is for protection of the digestive, reproductive, and urinary organs. And there's a base, an ala or wing, a sacral promontory, a sacral foramina, and an apex. Just terms identifying special parts of the sacrum itself. There they are, sacral foramina, transverse lines, etc. And then the sacral canal is just the pathway extending the length of the sacrum. It contains nerves and membranes. The spinal cord, the articular surface, and then the sacral tuberosity, which is the attachment site for the sacroiliac joint ligaments. There's a superior articular process, a median sacral crest, lateral sacral crest, and a sacral hiatus, which is the opening at the inferior end of the sacral canal. Then you get to the coccyx. This is 3 to 5 fused vertebrae, and they usually begin fusing about age 26. So there they are. You can pause the video, go back and review this section. Let's talk about the thoracic cage or the rib cage. This is our bony support for the thoracic wall. This protects the lungs, the heart, the sinus, and other thoracic cavity organs. It's composed of the thoracic vertebrae, the ribs, and the sternum. The ribs and sternum form the rib cage. The main muscles involved here are used for breathing and maintaining body position. as well as moving the pectoral girdles and upper limb. So the pectoral girdle is just the shoulder, the limb is the whole arm, right? So the sternum or breastbone has three major parts: the manubrium, the body, and the xiphoid process. The ribs are long, curved, and flattened. Ribs 1 through 7 generally increase in length and curvature. They're very mobile, flexible, and they're stabilized and held in place by connective tissue. There are several types of ribs. There's vertebrosternal ribs, which are ribs 1 through 7, which are true ribs. They connect directly through to our sternum through costal cartilage. Then you have vertebrochondral ribs. These are the ones that have shared cartilage. And then our floating ribs or vertebral ribs, these are ribs 11 and 12, and these are not directly connected to anything. The vertebrochondral ribs and vertebral ribs are also sometimes called false ribs, or 11 and 12 specifically are called floating ribs because they're not attached at all. So here you see them. The cartilage is, the costal cartilage is darkened in this just so you can tell the difference between that and the bones. You can also see the three parts of the sternum in this picture. So there are several parts to the ribs. They have a costal groove on the inferior border. They have a shaft and an angle where the shaft begins curving towards the sternum. They have a head or a capitulum, which is on the vertebral end, and then the tubercle, which is on the end that connects to the thoracic vertebrae. So there you see, this is the posterior view. This is anterior articular facet, the head, and then this superficial surface on the end would articulate with the back, the thoracic vertebrae. So rib articulations with the thoracic vertebrae, they have those costal facets. Again, the superior articular facet with the superior vertebrae, inferior articular facet with the superior costal facet of the vertebrae. So, and again, it's hard for me to teach this without having the rib here and just on a PowerPoint, but once you see it in lab, once you see how they fit together, it will make a lot more sense. The rib articulations with the thoracic vertebrae, ribs 1, 10, 11, and 12, their head articulates with just a single facet, and then the tubercle facets of ribs 1 and 10 attach to the transverse costal facets. There's no tubercular facets for ribs 11 and 12 because they're floating. There you can see how they attach. The ribs can move, just like the rib acts like a bucket handle when it's held out horizontally, so it can move and flex a little bit. Pushing down will move the rib inward. Pushing up will move the rib outward. The sternum moves along with it, so there's slight movement in those articulations. Movements will affect the width and depth of the thoracic cage, which can increase or decrease in volume, which assists with breathing. So there you see a little bit of rib movement. You can pause the video and answer these questions. We get into the appendicular skeleton. Here we're dealing with 126 bones. We have our pectoral girdle, our upper limbs, our pelvic girdle, and our lower limbs. So let's get cracking. You can pause the video, go back and answer these three questions. I'm going to keep going. The pectoral girdle or shoulder girdle, this is the connection between the arm and the trunk of our body. There's one on each side. There's an S-shaped clavicle and a scapula, which is broad and flat. Here you see a nice anterior view. Let's talk about the clavicle. It forms the sternoclavicular joint. The sternal end of the clavicle is more pyramid-shaped. It curves laterally and posteriorly. It articulates with the acromion to form the acromioclavicular joint, and this helps to stabilize the ligaments to special tubercles and tuberosities on that side. It has an acromial end, which is flatter and broader, and a rough interior surface for those tubercles. So again, this is the medial side, and this is the superior view, and this is the inferior view. The clavicle is probably the most difficult bone to tell left from right, so I'm going to try my best to give you those points when we're in lab so that you can identify them from each other. The scapula has a body, a superior border, a medial border, a lateral border, a superior, inferior, and lateral angle, and a suprascapular fossa. So lots of features to a scapula. It forms the glenoid cavity. This is where the scapula articulates with the humerus, and it forms what we call the glenohumeral joint, or a shoulder joint. It's most visible from the lateral sides when you're looking inward. The acromion is the large process that goes lateral. The coracoid projects anterior and superior to the glenoid cavity. There's also a scapular spine, a supraspinous, and infraspinous fossa. All of these we will be going over in lab. You can see them here in these pictures. You can pause the video, go back, and review the pectoral girdle. Let's talk about the upper limb. You have our humerus, our forearm, our wrist, and our hands. Let's talk about the humerus. It's only one. There's only one bone in the arm, or brachium. It extends from the scapula to the elbow. You have a medial and lateral epicondyle on the distal end. The head of the humerus is proximal. That's what's articulating with the glenoid cavity. You have an anatomical neck, which is basically marking the end of the joint. And then the surgical neck, which is the metaphysis, or growing part of the bone. This is the typical site for where fractures occur, at that surgical neck. That's where I broke mine, or shattered it really. But so the greater tubercle of the surface is a big rounded projection. The lesser tubercle is a smaller rounded projection. And then in between the two is a little sulcus called an intertubercular sulcus. It's a circus too. Why not? There's a deltoid tuberosity, which is the attachment site for the deltoid. This is on the lateral side of the humerus. There's also a radial groove marking the path for the radial nerve, and a radial fossa, which is where that radial head will kind of smooth into when the elbow is bent. There's condyles on the distal end of our humerus. There's a capitulum and a trochlea. The capitulum is very round, and the trochlea is more spindle shaped. It has kind of two little parts to it. Again, you'll see this more succinctly when we look at the humerus in lab. There you can see that trochlea versus here's the trochlea a little better. Trochlea and capitulum. This is in the anterior view. And the medial epicondyle is pretty easy to determine, and that's one of the ways you can feel them right from left. You can usually feel that on your own elbow, that little pointy part sticking out on the inside, hence medial, right? The ulna and radius, these are parallel bones of our antebrachium, anatomical position. The ulna is medial to the radius because your thumbs are facing out, your palms are forward. There's an interosseous membrane between the two shafts of these long bones. There's a proximal radial ulnar joint, a distal radial ulnar joint. So there's two joints between these two bones. The ulna has an olecranon, right? A trochlear notch and a coronoid process, all of which we'll review in lab. An ulnar head and a styloid process of the ulna are also on this bone. The radius has a radial head, which is on the proximal side, a neck, and a radial tuberosity, and an ulnar notch and a styloid process, which is on the distal end. Here they are. Again, you'll get to know them and see how they articulate more succinctly when we get to lab. It's a lot harder to learn these things by just looking at them two-dimensionally. You can pause the video, go back and answer these questions. Let's move on to bones of the wrist, or carpus. There's 8 of them. There's a scaphoid. There's a lunate. There's a triquetum, a pisiform, a trapezium, a trapezoid, a capitate, a hamate. Here they are. What I would do is I would memorize them in anatomical position by looking at a hand. Notice the pisiform is only visible on the anterior view. It's not on the posterior view, but all the other ones are. Let's talk about the metacarpal bones. These articulate with the distal carpal bones. So they're identified by Roman numerals 1 through 5, starting on the lateral side. So metacarpal 1 articulates with the trapezium and the thumb. So they start out here, just go right across. The phalanges, or finger bones, articulate with those metacarpals. There's 14 per hand. The pollex only has 2. All the other fingers have 3. They're named proximal, middle, distal, except for the thumb, which is just proximal and distal. There they are. You can see our metacarpals. You can see our carpals here, and you can see the phalanges. Remember, you drive a car with your carpals. Don't mix them up. Carpals and tarsals. There they are. You can review this on mastering or on Dr. Schaefer's class on YouTube. You can pause the video, go back and answer the questions. Let's move on to the hip bone. There's a pelvic girdle, which is made of 2 hip bones, or coxal bones. These coxal bones are each made of 3 fused bones, an ilium, an ischium, and a pubis bone. The pubic symphysis is the fibrocartilage pad connecting the 2 together on the anterior side. So here you see a lateral view. Here you see a medial view. of the three bones. Here you see an overall view of the entire pelvic girdle. You see the two coxal bones here, our sacrum in the back, and the pubic symphysis joint in the middle. That's the fibrocartilage pad. So let's talk about some of the features you see on the lateral side. You see iliac spines, gluteal lines, the greater sciatic notch, and the iliac crest. The ischial spine and ischial tuberosities are both features of the ischium. The ischium is the part that you kind of sit on. That's your butt bone, so to speak. The acetabulum is like a concave socket. This is where all three bones get fused together. So all three of them make up this area. And this is where the head of the femur sits. Here you can see what I mean. Ischial tuberosity, you have that greater sciatic notch here. You have your iliac crest, your acetabulum, where all three bones fuse together. And let's keep going. Iliac fossa, pectineal line, arcuate line. These are all more features that you would see from the medial side. Articular surface, iliac tuberosity, and obturator foramen, that's the big hole. It's bound by the ischial ramus, inferior pubic ramus, and superior pubic ramus. So you can see that obturator foramen right here, the big old hole. And then you see the ramus. Ramus is a projection. So you have ischial ramus, inferior pubic ramus, superior pubic ramus, pectineal line, arcuate line, and iliac tuberosity back here. Our auricle surface is where your sacrum will be bound. You can pause the video, go back and review. Let's keep going to the pelvis. The pelvis contains the bones of the axial skeleton and the appendicular skeleton, so there's lots of ligaments holding everything in place. They connect the sacrum with the iliac crest, with the ischial tuberosity, with the ischial spine, and the arcuate line. All the other ligaments connect the ilia and lumbar vertebrae. So your vertebrae are not just held in place, or your pelvic bones are not just held in place by the sacrum, they're actually attached to your lower back as well. The sacroiliac joint is the joint between the sacrum and the adjacent ilia. There they are. Let's talk about the divisions of the pelvis. So you have the true pelvis or the lesser pelvis. This is enclosing the pelvic cavity, and the pelvic outlet, which is kind of the hole at the bottom. This is bound by the coccyx, the ischial tuberosities, the ischial spines, and the inferior pubic symphysis. The greater pelvis is the blade-like portions of the ilia at the superior pelvic brim. So this is the top part. The lesser is the bottom part. There you see some of the differences between these two. And these are some terms that we'll be using: pelvic brim and pelvic inlet, right? Inferior view here, looking kind of up into someone's pelvis, just their bones. Female compared to male, differences are due to body size and muscle mass, but overall female pelvis is smaller, lighter, has less prominent markings. Obviously, it has adaptations for childbearing, like an enlarged pelvic outlet. Thank you. Broader pubic angle. In other words, the pubic bones are not as close together like this. They're a little wider, right? A lesser curvature to the sacrum and coccyx. It's more flat. Wider, more circular pelvic inlet, and a broad, shallow pelvis. You can see by looking at these two very clearly what the difference is. You should know these differences. You can pause the video, go back, and review. Sorry, I just keep shifting. This chair is not very comfortable. I usually sit on a pillow. Let's talk about the lower limb. We're almost done here. It's been a long lecture, I know. Our lower limb is transferring our body weight to the ground. So this is our thigh, our leg, including our tibia and fibula. Don't mix those two up. There's nothing called a tibula and nothing called a fibia. Please, please don't make that mistake. Oh, it drives me nuts. It's connected by an interosseous membrane. There's the kneecap, the patella, there's the tarsals, metatarsals, and phalanges again. Let's talk about the femur. Largest, heaviest bone in the body. Articulates with the hip joint, articulates with the tibia at the knee joint. Major landmarks. Femoral head has a fovea capitis. This is a little pit allowing for attachments to the acetabulum, and then there's a neck as well, connecting to the shaft. There's a greater and lesser trochanter and intratrochanteric line, and a gluteal tuberosity. It's very similar to the humerus. Everything's just a little bigger. A linea aspera, a popliteal surface, the medial and lateral condyles, all structures on the femur. There they are. You'll get to know and love them in lab. Then you get to the patella, the base, the apex, the lateral and medial facets. There they are. Then we get to the tibia. This is our shin bone. This is what you feel when you touch your shin. It has intercondylar eminence. It has a tibial tuberosity. It has an anterior margin, and it has a medial malleolus. The tibia is what you feel on the medial side of your ankle. The fibula is a small slender bone. It parallels that lateral border of the tibia. It does not participate in the knee joint, so it's not articulated there at all. It doesn't bear any weight. It's more of an attachment site for muscles of the feet and toes. The head of the fibula articulates with the tibia, and the lateral malleolus is the outer ankle bone that you feel. So when you touch the outside of your ankle, you're touching your fibula. When you touch the inside of your ankle, you're touching your tibia. There they are. You can see what I mean down there at the distal end. Here's what we mean at that proximal end, where it's just that tibia articulating with the femur. You can pause the video and answer these 3 questions. Let's talk about the functions of the foot and ankle bones. Ultimately, they're bearing your entire body weight. They're transferring that weight to the ground. They're distributing the weight to your foot bones, and they have to be held together by very strong, flexible tendons. So there's 7 tarsal bones. The calcaneus is our big, heavy heel bone. There's a talus, which is transferring the weight from the tibia to the toes. There's a navicular, a cuboid, and cuneiform bones. The cuneiform bones are medial, intermediate, and lateral. So here they are. Calcaneus is this big heel bone. Our talus is where our tibia sits, and then navicular and cuboid, and then our cuneiform bones, medial, intermediate, lateral. And then same thing with our metatarsals. You start medial and go lateral with the numbers, and then phalanges, proximal distal, or proximal middle distal for our toes. Metatarsals form that distal portion of the foot. They proximally articulate with the cuboid and cuneiform, and distally articulate with the proximal phalanges. And again, they're Roman numerals 1 through 5. Phalanges, same thing, except it's called a hallux, not a pollux, and there's a link to proximal, distal. Everything else has proximal, middle, and distal. There they all are in all of their glory. Here's the video that's not going to work because I'm not playing the PowerPoint. I'm just clicking through it. You can watch them on Mastering A&P. Let's talk about arches of the foot. There's a longitudinal arch, which is formed because of ligaments and tendons connecting the calcaneus to the distal metatarsals. It's allowing for the transfer of weight. There's a lateral, less elastic portion, which has much less to do with the curvature than the medial portion. So it's basically just there holding all of the foot bones in place, allowing for the transfer of that weight to be equal. The transverse arch is due to the degree of longitudinal curvature, changing from medial to the lateral border. So this is what we think of as the arch of the foot. So there you see the longitudinal curve this way, and then a transverse curve this way. Most people, when they're referring to flat feet, are referring to this transverse arch. Dancer's fracture is usually a fracture in that 5th metatarsal because the body weight is being supported by that longitudinal arch in that like ballet type dancing. A sudden shift in the weight can cause that to happen. That lateral part is less elastic, so it typically breaks that 5th metatarsal, very close to the small toe. Very painful, very slow healing, unfortunately. These questions you can answer on your own by pausing the video. I think we are done. So with that said, let me know if you have questions. I will see you in lab. Again, I apologize for flying through this. The majority of this we will be covering in lab, so I didn't feel it was worth your time spent sitting here listening to me describe things when you're just going to see it in lab. So hopefully it didn't blow your mind too much, and if it did, just ask questions. All right, see ya.